to a family friend of mine fairly recently and is the inspiration for this talk. So you have a 24-year-old female who's brought into the emergency room by her roommate. And the history is coming from the roommate. The roommate said she came home to their apartment kind of late at night, around 2 in the morning. She'd been studying in the library. And she heard some strange noises coming from the patient's room. So she went in and found her roommate. She appeared to be sleeping in her bed, but she was making some strange noises and she was doing some strange movements. And as far as the roommate knows, the patient doesn't have any known medical problems. So what do you guys think is going on?
Overdose, suicide,
seizure, meningitis.
Yeah, good. Nice broad differential. So say we're going to pursue the diagnosis of seizure. What are your immediate actions? Yeah, ABCs, finger stick, all good. All right. So we'll be thinking about that. Now I'm going to show a video of a patient in an epilepsy monitoring unit. But for our purposes, let's say this is a patient in the stretcher in the pod. She's in 2 hallway, and the chief complaint is seizure. And you just see her on the board. Her vital signs are normal. She appears drowsy, maybe post-ictal, pretty comfortable, and she's like 10th on the list to be placed. So you're not going to pick her up yet. You're just going to keep your eye on her. And when you're watching this, so the top leads are the EEG. I want you to pay attention to the bottom lead, which is the rhythm strip from the EKG. And her seizures were described as being like this. So clearly, this patient did not have a seizure, right? She had a potentially fatal cardiac arrhythmia. She had torsades. So that brings me to the topic of my talk, which is arrhythmias masquerading as seizures. Something that is not by any means common, but we should be aware of. Just to bring it back to the case, my friend, she was brought in to the ER as having a seizure and worked up and actually found to have BRUGADA. So learning objectives. My primary learning objective for you all, I want you to remember to consider cardiac illness in all of your seizure patients. Remember to get the EKG, and there are some cardiac dysrhythmias you can look for. We can catch these in the ER, long QT and BRUGADA. I'll cover both of those, and then I'll briefly talk about the phenomenon of sudden unexplained death in epilepsy patients as something to be aware of and an argument for using monitoring in our higher-risk patients. And just a little disclosure, this topic can get a little complex if you really do a deep dive into it. So this talk is by no means an explanation of all of the potential cardiac conditions that can mimic seizures, nor is it an explanation of the pathophysiology underlying the overlap, because it can get pretty complicated and we aren't even fully aware or sure of how these things can interplay. But rather, it's an effort to remind us to utilize EKG and cardiac monitoring So first up is long QT. Long QT syndrome is a disorder of myocardial repolarization. Results in QT prolongation on the EKG, and this can predispose to torsades. QT can be congenital, so you're born with it, or acquired. There's a really long list of drugs that can predispose you to long QT, and it can also develop from electrolyte disturbances, primarily low potassium, low magnesium, and low calcium. When you're looking at the EKG, especially for syncope patients or seizure patients, I urge you to look at the QT interval, and if it looks long, calculate it yourself. The calculated QTCs that are reported by the EKG machines are notoriously inaccurate. There are algorithms you can look up on the internet, just Google like QTC calculation, and you can plug it in. It's pretty easy to do yourself. So if the interval looks long and you have a reason to be concerned, calculate it yourself. For our purposes, in a symptomatic patient, QTC cutoffs are 470 for males and 480 for females. But if you can't remember that, a good number to remember is over 500. Long QT syndrome is by far the most documented arrhythmia that can mimic seizures. One study of individuals who were tested genetically for long QT syndrome, 29% of them had a seizure history. And for these patients, the history can be particularly helpful. There are some classic triggers in long QT patients that can trigger an arrhythmia or seizure-like activity. Those are exercise, and they also frequently occur during nighttime sleep. Sunday. Everyone knows Sunday, right? So next up, BRUGADA. We all knew BRUGADA. You guys got that question right on the in-service. It's classically young males. They present with syncope. They're at high risk for ventricular tachyarrhythmias and sudden cardiac death. It's caused by defective sodium channels in the myocardium. And it's an autosomal dominant genetic disorder. Highest estimates are prevalence of about 1% in the general population. I always have to look up the EKG changes when I'm thinking about BRUGADA. I kind of remember it looks funky in V1 through V3, the ST segment. The most common abnormality is this sort of pseudo RSR prime right bundled branch block pattern in V2. So V2 is primarily where you want to look. So this is the classic coved RSR prime pattern, but you can also see this saddleback pattern as well in types 2 and 3. So BRUGADA masqueraders. Seizures are less common reported manifestation of BRUGADA syndrome, but it does exist in the literature. There are a few case reports. So one is that fever is a known trigger of VTAC in adults with BRUGADA. And there are actually case reports of infants being brought in for multiple visits to the ER for fever, decreased levels of consciousness, and seizure-like activity, and they're later found to have BRUGADA. And there are also case reports of adults coming in with status epilepticus, and they get an EKG recording while the patient is having seizure-like movements and they're in VFib. And then when they get an EKG after that has ended, it shows the BRUGADA pattern. And finally, sudden unexplained death in epilepsy patients. This is something I never really heard of until I was doing my research for this talk. But it's exactly what it sounds like. It's a known phenomenon in epilepsy patients, and it's thought to be due to a fatal arrhythmia. It's actually the leading cause of death in patients with uncontrolled epilepsy. So the prevalence about 1 in 1,000 adults and 1 in 4,500 children will experience this. The mechanism, it's not entirely clear. Most theories are that it's a fatal heart rhythm, and that mostly comes from research of individuals with fully controlled epilepsy being monitored and sort of catching them surviving these fatal cardiac arrhythmias. Other potential mechanisms are prolonged apnea or acute heart failure. But most importantly, most cases occur during or immediately after the individual has a seizure. So this is a time where we are often seeing these patients in our ER, and something maybe we might be able to catch. Certain patients are more at risk for this than others. So risk factors for sudden unexplained death are frequent or uncontrolled seizures, patients who've had epilepsy for many years, a young age at onset of seizures, non-compliance with medication, alcohol use, and being male. So I don't know about you guys, but I feel like I've seen a number of patients with all of these risk factors in our ER, and just something to be aware of, maybe be a little bit more vigilant, have these patients on a monitor from the time they come in, and be vigilant with them. So running points.
There was recently.
Yeah, I heard about this, and I didn't have the details of this case, but I heard there was a patient in CCT who maybe had something similar. I don't know if anyone's here who had that.
It's an attending
Um,
It's an added
So get the EKG and repeat it as needed. So get it not only when the patient first comes in, but if they're post-ictal for a while and they start to have seizure-like activity again, I don't know how many times they're protecting their airway or waiting on the nurse to bring the Ativan. Try and get an EKG if possible. You might find something. And look for QT prolongation. Look for BRUGADA. These are things we can catch. And finally, put them on a monitor, especially our higher risk patients. That's it.
I just want to fill the plug in. Number one, I think the two strongest takeaway points here are that the brain controls the heart and the heart produces the brain. And I kind of learned that the hard way with a very similar case. I had a lady, not CCT, but UHB, who could give no history. She had an underlying side family, were poor historians. And the only reason I caught the fact that she wasn't having a seizure and was having really terrible dysrhythmia was because we had her on a monitor. So it's extremely important for all your seizure patients to be on a monitor for two reasons. Number one, cardiac can masquerade as neurologic, and number two, you're just never going to know unless you, for some people, unless you catch them during that seizure-like activity, which an EKG that you then have to slap on the leads afterwards, and may not happen, or it may happen after they're out. So.
Yeah, I thought it was a great talk. I think it's an important talk. It shows that you have to always do the ABC, and then it's just checking the pulse and make sure they're not in arrest. My mother, when she had B-fib, and eventually wound up dying from it, when she had B-fib, she presented as seizure. She never had a seizure before in her life, and it was because she wasn't perfusing one part of her brain as well as another, and went into seizures. And we actually shocked her out of it, but she never really woke up. So you want to check that. The other thing you talked about is someone having a seizure who's at risk to then cause arrhythmias because of sympathetic outflow and other things. And there was a famous case many years ago. The older ones here, and I remember Tony Dorsett, famous running back for the Dallas Cowboys. His girlfriend died from that syndrome.
I thought this was great. I actually had a case just last week at UHB about a nonverbal patient who came in with adult onset seizure. It was post-ictal, had lactatemia, but we did a screening ECG that showed actually a stemming in the lateral leads and trended up to like 90 in CCU. So I think it's worked through the cardiac with these patients.
Thank you, Dr. Benson.
All right, everyone, you have 5 minutes while we prepare for M&A.